Imagine this, right? You make a quick cut, maybe playing sports, maybe just stepping weirdly off a curb, and bam, sudden sharp pain, that awful popping sound. Your kneecap, the patella, it's just slid right out of place. It's shocking, really vulnerable feeling. And if it's your first time having a patellar dislocation, there's this huge question just screaming in your head. Okay, what now? Surgery or something else? This isn't just about the pain, though. It's actually a really long-standing, kind of complex debate in medicine, and that's what we're diving deep into today. Our mission really is to unpack this whole debate. What is the best way to treat a first-time patellar dislocation? Do you operate or not? And we're basing this deep dive on a fantastic systematic review. It's called To Operate or Not, Evaluating the Best Approach for First-Time Patellar Dislocations. A review, it's by Tedeschi and colleagues, published just this September in the Journal of Clinical Medicine. Think of this paper as like a shortcut. It pulls together findings from lots of really solid studies, giving us a much clearer picture, helps us get informed, fast.
Yeah, and it's fascinating because the medical world has been wrestling with this for, well, for decades.
Yeah.
You've got one camp saying, immediate surgery offers stability, maybe better long-term outcomes. Then there's the other side, advocating for conservative treatment, non-surgical stuff, mainly to avoid the risks that always come with an operation. So yeah, we're going to dissect the evidence from this review, look at the nuances, maybe even challenge some assumptions you might have.
Okay, so let's just set the scene properly. What is a patellar dislocation?
Well, it's pretty much what it sounds like. Your kneecap, that little bone at the front of your knee, it completely shifts out of its normal track, the groove at the end of your thigh bone.
And it happens more often than you might think, right? Especially in certain groups.
Exactly. It's particularly common in adolescence and seems to affect females a bit more often. And the problem isn't just the initial pain and the dislocation itself. You often end up with ongoing issues, things like the knee feeling unstable, like it might give way, persistent pain, difficulty getting back to sports or even just daily activities. And there's a risk of long-term problems, too, like developing arthritis earlier than you might otherwise.
So when this happens, what are the main forks in the road, treatment-wise?
Broadly speaking, two main philosophies. First, there's conservative treatment. This is the non-surgical route. Usually means immobilizing the knee for a bit, maybe with a brace, let things calm down. Then, a really structured physical therapy program. Strengthening muscles, getting function back. The big appeal, no surgery.
Okay, that makes sense. And the alternative?
The alternative is surgical intervention. This could involve various procedures, but a common one is reconstructing the medial patellofemoral ligament, or MPFL. Think of the MPFL as like a key tether holding the kneecap in place. If it's torn or just not doing its job, surgery aims to rebuild or reinforce it. It's about directly fixing any anatomical problems that made the dislocation likely in the first place.
So you're physically trying to stabilize it.
Precisely. Goal is to stop it from popping out again.
Okay, let's unpack this then. We've got the conservative path, less invasive, avoids surgical risks, but historically at least, maybe a higher chance of it happening again.
That's been the traditional knock on it, yeah. Higher redislocation rates.
And then surgery. Might give more stability up front, but it's still surgery. Comes with risks, infection, other complications, maybe a longer recovery. It's a real trade-off.
It absolutely is. And that's the core dilemma this Tedeschi review tackles head-on, trying to find some clarity based on the best available evidence.
So how did they go about finding that evidence? What kind of studies are we talking about?
Well, this was a systematic review, so they were really methodical. They searched the big medical databases, PubMed, Scopus, Web of Science, looking specifically for randomized controlled trials, or RCTs.
The gold standard in clinical research.
Exactly. They focused on RCTs published between 2013 and 2024, so pretty recent data. They ended up including 7 RCTs in their final analysis. All told, that involved 411 participants. So it's not a huge number in the grand scheme of medicine, but for this specific question, pooling 7 RCTs gives us a pretty robust, up-to-date look.
And what were they measuring in these studies? What were the key things they look for?
Their main focus, the primary outcome, was the redislocation rate. Basically, how often did the kneecap pop out again after the initial treatment, whether surgical or conservative? Then they looked at secondary outcomes, things like knee function, often using something called the Kujala score, which is a questionnaire where patients rate their pain and ability to do activities. They also tracked complication rates from both types of treatment and whether people needed any further surgeries or interventions down the line.
And they checked the quality of these studies too, right? It wasn't just about quantity.
Absolutely. They used established tools, like the Pedro scale, to assess the methodological quality of each RCT.
Hmm.
This helps gauge how reliable the findings of each individual study are.
So we're looking at data that's been pretty thoroughly vetted, gives us more confidence.
Definitely. It means we're not just looking at any studies, but ones that meet a certain standard of scientific rigor.
Okay, so the stage is set, robust review, quality studies. Let's get to the big question. Does surgery actually stop the kneecap from popping out again? What did the review find?
Here's where it gets really interesting. The overall trend they found was, yes, surgical treatment generally led to lower redislocation rates compared to conservative management.
Generally lower. Can you give us some specifics? Like how much lower?
Sure. So, for example, one study by Askenberger and colleagues in 2018, they reported a statistically significant difference. 16 redislocations in the group treated conservatively, compared to only 8 in the surgical group.
Wow, half as many.
Yeah. And another study, Patellar et al., from 2012, found that 35% of patients in the conservative group experienced either another full dislocation or what's called a subluxation, where partially pops out but goes back in. Still a sign of instability.
Okay. And the surgical group in that study?
0. No redislocations or subluxations reported in the surgical group in Patellar study.
0 versus 35%. That sounds pretty definitive.
It sounds definitive, and it is a striking difference, but like with most medical research, there are important nuances here.
Ah, okay. Always nuances. What are they here?
Well, while 6 of the 7 trials showed this trend favoring surgery for preventing redislocation, we need to look closely at the statistics. Take that Askenberger study with the 16 versus 8 redislocations. The difference was statistically significant, but the p-value of that measure of statistical probability was 0.047. The standard cutoff is often 0.05, so it just squeaked under that threshold. Meaning, while the result favors surgery, the margin isn't enormous. It suggests surgery is likely better, but maybe not overwhelmingly so in all cases. Based on that specific study's statistics alone, you have to consider the whole picture.
Right, and you mentioned older studies earlier. How do they fit in?
That's crucial context. There were influential studies by Niku et al. Back in 1997 and 2005. And interestingly, those studies did not find that surgery significantly reduced redislocation rates. In fact, in those older trials, surgery was linked to quite a few significant complications.
So older surgery wasn't necessarily better and might have been riskier.
Exactly. And this really highlights how much surgical techniques have evolved. The way MPFL reconstructions, for example, are done today is often much less invasive, much more precise than what was being done 20 or 30 years ago. So those older results might not fully apply to modern surgical practice.
Okay, that makes sense. Techniques improve. So surgery seems to have an edge, especially modern surgery, in preventing redislocation. But what about just feeling better? Getting back to normal life, knee function?
Now that's where the picture gets much more complex. When you look at knee function, often measured by that Kuchala score we mentioned, the results across the studies were really quite mixed. Not a clear win for either side.
Mixed how? Some showed surgery was better, some didn't.
Pretty much. You had studies like G et al. In 2016 and that Patellar study from 2012. They did report significantly higher Kuchala scores, meaning better function, in the patients who had surgery. They felt better, could do more.
Okay, so points for surgery there.
But then you had other studies, like Askenberger et al.
Hey.
and Salanpa et al. From 2009. They found no significant difference in Kuchala scores between the surgical and conservative groups. Some even noted slight advantages for conservative treatment in certain patient-reported aspects.
Huh. So why the inconsistency? If surgery often stops it popping out, wouldn't function automatically be better?
You think so, but it's not that simple. The review suggests a few reasons for this mix. One is the variety of surgical techniques used across the different studies. Not all surgery is the same. Another factor is differences in the rehabilitation protocols after treatment. How good was the physical therapy? How consistent? That hugely impacts function, regardless of the initial treatment.
Right. Rehab is key.
Absolutely. And finally, patient demographics matter. Age, activity level, whether they had underlying anatomical issues like we discussed earlier, trochlear dysplasia, patella alta, all these things can influence functional outcomes and make comparing studies tricky.
So just stopping the dislocation isn't the whole story for how well someone recovers functionally.
Exactly. It raises a really important point. Maybe focusing only on the redislocation rate doesn't capture the full patient experience or their overall quality of life after the injury. Functional recovery is, well, it's multifaceted.
Okay, so redislocation maybe favors surgery, function is mixed. But what about the downsides, the risks? You mentioned complications with older surgery. Is that still a big concern? This feels like the catch.
It is the catch, or at least it has been historically, and it's a major consideration for patients, obviously. Surgery inherently carries risks that conservative treatment avoids. And those older NICU studies really drove this home. They reported some quite severe complications back then, things like sciatic nerve palsy, which is serious nerve damage, and deep infections requiring more surgery.
Yikes.
Yeah. And across those two NICU studies, they documented 61 additional surgical procedures needed in the operative groups over a 7-year follow-up period. That's a lot of extra intervention.
That definitely paints a cautionary picture. But you also said techniques have improved.
Massively. And that's the encouraging part. More recent studies included in this review, like Salampa et al., 2009, and Regalado et al., 2016, reported 0 re-interventions needed in their surgical groups.
0. That's a huge improvement.
It's a night and day difference. It strongly suggests that modern techniques are not only more effective at stabilizing the kneecap, but also much safer, with fewer subsequent problems requiring more surgery.
That changes the risk-benefit calculation quite a bit, doesn't it?
It does. And interestingly, that Regalado study also reported 9 reoperations needed in the conservative group, mainly because the kneecap dislocated again and they eventually opted for surgery later, compared to 0 in their initial surgical group.
So avoiding surgery up front doesn't always mean avoiding surgery forever if the conservative approach fails.
It's another layer to consider. Yes, sometimes conservative treatment leads to needing surgery down the road anyway.
Okay, this is a lot to weigh. Lower redislocation with modern surgery, but mixed results on function. And while surgical risks seem lower now, they still exist. Conservative avoids initial risks but might fail. So what's the bottom line? What does this all mean for someone facing this decision? For you, the listener, if this happens.
I think the biggest, clearest takeaway from this review, and from clinical practice, is that there is no single best answer that fits everyone. The decision has to be individualized, highly individualized.
Meaning you look closely at the specific person.
Exactly. Clinicians need to weigh up several patient-specific factors. Age and activity level are critical. A young, highly active athlete, especially in cutting or pivoting sports, their risk of redislocating is much higher. Missing a season due to a second dislocation is a big deal. For them, the potential benefit of surgical stability might outweigh the risks more clearly.
Makes sense. And for someone less active?
For an older person, or someone with lower physical demands, maybe the risks of surgery loom larger and the potential benefits of avoiding another dislocation are less critical to their lifestyle. Conservative management might be perfectly appropriate, even preferable.
What about the knee itself? The anatomy?
Huge factor. Those anatomical predispositions we touched on, like trochlear dysplasia, where the groove is too shallow, or patella alta, where the kneecap sits too high. If you have those underlying issues, your risk of redislocation is significantly higher, even with good rehab.
So those might push you more towards surgery?
Often, yes, because conservative treatment can't fix the underlying architecture. Surgery might be needed to address the root cause and offer durable stability. Then you also have to consider comorbidities, other health issues, things like obesity or generalized ligamentous laxity, meaning naturally loose joints, or pre-existing arthritis. These might increase surgical risks or influence the type of treatment recommended. Conservative care might be favored sometimes.
So it really is a complex puzzle, putting all those pieces together for each person.
It is. And that's why patient education and informed consent are absolutely paramount. It's not about the doctor telling you what to do. It's about the doctor explaining the evidence, the pros and cons of both options as they apply to your specific situation, your knee, your life, your goals.
A shared decision.
Exactly, a partnership. So you, the patient, can make a choice you feel confident about, understanding the potential journey ahead, whichever path you choose.
Are there new things on the horizon that might change this picture even more? New techniques?
There are definitely ongoing developments. We're seeing more refinement in minimally invasive surgical techniques for MPFL reconstruction, for instance, using things like bioabsorbable anchors, screws, or fixation devices that dissolve over time.
So no need to remove hardware later?
Potentially, yes, and maybe faster recovery. On the rehab side, there's a lot of innovation, too. Things like advanced neuromuscular training, really focusing on retraining muscle firing patterns for better joint control. And using tools like proprioceptive taping, special tape applications that give your brain better feedback on joint position.
Small things that could make a difference.
They can add up. But, as the review also points out, We still need more high-quality research on many of these newer approaches to really nail down their long-term effectiveness compared to established methods. The learning never stops.
Okay, so let's try to wrap this up. What have we learned from this deep dive?
I think the core understanding is this. Modern surgery often does a better job at preventing the kneecap from popping out again after a first-time dislocation. That seems clearer now than perhaps it was decades ago.
Uh,
But its advantage in terms of overall knee function isn't always as clear-cut. Results there are more mixed. And surgery, even modern surgery, still carries inherent risks, though they seem to be lower than in the past.
and conservative treatment.
It remains a very valid option. It's less invasive, avoids surgical risks up front, and for some people, particularly those without major anatomical red flags or with lower activity demands, it can be very successful.
So no easy answer.
No easy answer, but a clearer framework for making an individualized decision. It's about balancing the benefit of potentially fewer redislocations against the surgical risks and the uncertainty around functional gains. It all comes back to the individual patient, their anatomy, their lifestyle, their tolerance for risk, their goals.
It really makes you think, doesn't it? Considering how much better surgery seems to be getting, how do you even begin to quantify the long-term impact on someone's quality of life? Is avoiding even one more dislocation worth the upfront risk and recovery of surgery?
That's the million-dollar question, isn't it?
How would you weigh that?
The relative certainty of fewer dislocations with surgery versus the unknowns of functional recovery and potential, albeit smaller, complication risks. Something for everyone to consider if they, or someone they know, faces this tough situation.